that it has not. There's none in the lymph nodes, so that's how we got to 1A.
Okay. Sorry, I accidentally scrolled through here. Okay. Yes. One of the other ways that you can do this is, if you go to guidelines, you can actually look. They'll give you a exact kind of corresponding TNM staging with your stage. So this is called the kind of pathological staging, and this is more the clinical staging. And this staging, the stage 1A or B or 3, whatever, is really important for clinicians to understand goals of therapy for patients, but also to help patients understand staging. Because patients really, if you say to somebody, hey, this is good news, you got T1N0M0, and they're like, what the hell are you talking about? People understand things in terms of stage. This is common terminology. So it's good or terminology rather. It's good for being able to describe that to patients and other clinicians. Okay, so Team 5, what endocrine therapy and what duration did you choose out of this list?
We chose A, anastrozole for 5 years.
Perfect. And why did you do that? Besides the fact that it was on the slide.
Because based on your slides, it said that it was category 1 recommendation for postmenopausal women.
Exactly. And I got asked a question about how much, do I need to know about when to continue therapy for an additional 5 years, or, which other therapies you need to choose if you're on tamoxifen premenopausal and then you become postmenopausal. Remember, I told you in that lecture that I don't need you to know that. And there's so much debate about how long to continue these therapies and so many patient-specific factors that I really didn't want you to concern yourselves with that crazy bifurcating chart. I really more just want you to understand what we start and why we start it, and when we start it for patients based on their menopausal status. So that was awesome. Thank you, Team 5. Appreciate that. So for Team, let's do Team 6. For the therapy that you selected, what patient education would you provide this patient, and what monitoring would we need to do while she's on therapy? So we decided anastrozole, right?
Yes, so we decided on anastrozole. They're going to take 1 mg PO daily for 5 years, and they're going to take it at the same time every day, with or without food. The main things to monitor with anastrozole is the osteoporosis. So they should do screening, like bone screens, frequently. And then counseling point on the side effects is the hot flashes, the DVT, PE, bone pain, and hypersensitivity.
Perfect. Yeah, that's awesome. And in terms of osteoporosis monitoring specifically, do you guys remember what kind of scans or what kind of screening mechanisms we use?
DEXA?
Yeah, that's right. Yeah, absolutely. And how often do you think we need to do them?
I think it depends on their BMD, usually, where they're at. But anywhere from, depending on where they're at on that scale, 1 to probably 5 years.
Exactly. Perfect. And I would say with a lot of these patients, because we know that their risk of osteoporosis is much higher than the average patient, we often will do every year, every other year. And it depends, again, you're exactly right on what their score is. Awesome. Thank you. Okay. Now for question number 4, couple of things. I gave you some clues, right? So I said, all right, we're using dose-dense adriamycin, and we've talked in the febrile neutropenia lecture about dose-dense. So can Team 9, can you talk to me about what does the term dose dense mean? Hello, Team 9.
It means we're just giving them multiple doses in a row, usually a higher concentration.
So higher concentration or decreased frequency?
Decreased frequency.
Right. So, I mean, no, increased, yeah, sorry, decreased interval is what I meant. Right, so a decreased interval. So that means that we're, instead of waiting for someone to recover, right? So let me just stop sharing for a second here. Okay. I'm going to pull up the whiteboard really fast so you guys remember this drawing. Okay. So when someone starts a chemo, cycle 1, their white count is and their red count are up here, right? They hit their nadir. It goes to its lowest point. They're at their lowest point, and then they start to recover, and then they get their next cycle, right? So then this is cycle 2. When we do dose dense, we usually cut that interval in half. So that means that they only have a short period of time to recover for the next dose. Okay? So that's what dose dense.
Dr. Leva?
Yeah.
All we see is a white strip on your screen. We can't see anything that you're pointing to.
No. Oh, crap. It was such a good drawing, too. Okay. Hang on a second. It's so weird. Okay, stop sharing. All right, I'm going to try that one more time. If it doesn't work, then I'll try to draw it in the... Okay, can you see that now?
Yes.
Yes.
Okay. All right, so we started off with cycle 1, right? And then this would be the normal
That's
time.
not working now.
What's that?
Back to the white strip.
No, we only see like a line, like a stripe.
Oh, it's still not working. Okay. Damn it. All right. Okay, let me see if I can do this instead. Sorry. Technology is wonderful, especially when it works. Okay. All right, you can see my screen again, right? The breast cancer case? Okay.
Yeah.
All right, so let me just draw this really fast. Okay, so cycle 1, right? Their white count is up here, and then they hit their nadir, and they have to recover for cycle 2. Can you see the drawing?
Yeah.
Okay, great. When we do dose dense, we're usually cutting that time for recovery in half, or we're knocking off a week or so until the next dose. So that means that we're going to give a dose here, and then we're going to move cycle 2 to right here. So we're not allowing somebody to recover, which is why we have to worry about potentially giving them a growth factor, right, to get to this point so that they can continue on cycles. We do dose dense because we know that we get maximum kill of cells, right? Because it means we're able to kill way more cells if we keep hitting somebody over and over and over again. So I gave you a clue, both of the dosing and the interval frequency when I said dose dense adriamycin Cytoxan and then weekly Taxol. So probably one of the best places that you can go. You can go on to the NCCN guidelines and just do a search on the breast cancer guidelines and just do literally type in, doxorubicin, Cytoxan, and you should be able to find it'll say dose dense or whatever, and then you can look for the actual reference and go through and look in the reference to see, okay, what was the rate of febrile neutropenia? Incidentally, what immunogenicity risk is adriamycin and Cytoxan?
Hi.
Exactly. So that should help you also cascade out some of the other treatment recommendations that you're going to have, right? Okay. So for the next couple of questions, what I'm going to do is I want you guys to go back to the drawing board and work some more on this. If it's easier for you, if for whatever reason people are having a hard time logging in and getting references, or I'm sorry, getting the NCCN and guideline references for your use, I can go ahead and post the newest version of the breast cancer guidelines. Just understand that they're voluminous, and the only thing that's going to help you is really just being able to look up the original references to see dosing and things like that. Okay? Would that make it easier for people if I did that?
Yeah. So once again, when you said look up NCCN guidelines, I punched in the drugs, and I was able to open up a chemotherapy order template.
Yeah.
So when you're saying reference, there are some references. So basically just type in those references and look them up on PubMed. Sorry, PubMed.
Yes, exactly. And that's
triangulate where they got these.
Exactly, because you know what? The order sets are great, and that's a really good place to start because it does give you a sense of like, oh, okay, this is where you got the dose, whatever. But when I'm providing a reference for PNT, for example, or if a provider is asking me to create a template, I can't just base it off of the NCCN guideline templates. I can say I use this as a starting place, but the references that they created a template from are X, Y, and Z. So you want to make sure that you have a way of backing it up, because sometimes, I mean, very rarely, but on occasion, the guideline references have been wrong or missing information that you really need to have a complete order set. Because the order sets that they provide are, they're pretty decent, but they're not complete for most institutions. It's just
so
a good.
Doctors are trying to look at they're basically okay. Let's say you're on your rotations. They ask you a random question, and let's say I did the same thing, and I'm looking it up, and I go back to the reference. They're gonna want to know what their patient, how similar their patient is to the where you looked up the answers from, correct? That's what they're trying to look at?
Exactly. So, in general, by the time you get asked a question about a drug, almost always, especially on rotation, you'll be told, at least from an oncology perspective, you'll be told what their diagnosis is. So you'll be able to make your decision based on, okay, yeah, this is appropriate for this patient. Or they'll just ask you like, hey, we want to start the patient off on dose-dense adriamycin Cytoxan. Tell me what the usual doses are for this indication. So you'll probably get prompted with quite a bit of information. You're just going to have to focus more on kind of the therapeutic aspect of it, which is why I gave you the drugs specifically to look up, because that's probably how you'll see a lot of the DI questions that you're asked. You may get also, hey, I've got this patient with this disease state. Can you look up to see what lines of therapy we might potentially use? But that's a much more advanced question that you might not necessarily get on a rotation. It's possible.
Okay, thank you.
Yeah, no problem. Okay, so before we break for the day, and I know I have some exam review time scheduled with a bunch of you, I'm going to come on to my office hours from 1 to 2, but I have a meeting with a student from 1 to 1:30. So I'll pop on at 1:30, and then, anyone else who needs to schedule, to see their exams, again, just remember you have to have your camera working, and Dr. Fox and I are trying to work together to schedule those, particularly before Friday, if people are going to want to do the retake. So just make sure you reach out to us, and we'll do whatever we can to schedule. Okay, any other questions before I let you go and see you on Thursday and we cover all of this in great detail?
Dr. Fox, I have a trouble finding question number 5D.
Okay.
I can't find, if this regimen, which is Herceptin, Perjeta, and Taxol, cause febrile neutropenia. I can't find it. I'm trying to look at the studies, but I don't know. I can't find it.
So it's okay. Yeah. So the studies are out there because the combination is approved, right? That's a very common regimen. I would just encourage you, if you're not finding the word specifically febrile neutropenia, what you may want to do is look at the weekly Taxol by itself, okay? And then Herceptin, Perjeta by themselves, and see if you can find the rate of febrile neutropenia in the studies. Now, if you don't see anything, if you just see neutropenia and grade 3 infection, remember we talked about how
that is febrile neutropenia.
Right. It's sort of, I mean, it's like kind of a crappy designation because it's not exactly, but we can assume that it's could be their equivalent of febrile neutropenia.
Okay.
Yeah.
Okay. Thank you.
Yeah, no problem. Okay. Any other questions? It's 12:01. All right. Well, thank you guys again for participation. And my P4s, please hang on because I want to chat with you guys for a couple minutes. And to everyone else, good luck tomorrow on PCOA. All right. Thanks, guys.